Turp and Turp syndrome. The cardiovascular and CNS complications associated with the intravascular absorption of non-electrolyte irrigating solutions, which can result in acute changes in intravascular volume and plasma solute concentrations. Anesthetic considerations for Turp patient. 1. Often elderly, with coexisting disease. 2. Obstructive renal failure. 3. Alpha blockade, i.e. terazosin, may exacerbate hypotension. Surgical. 1. Considerations of intraoperative complications. Turp syndrome. Concealed hemorrhage, average 2 -4 cc min, hypothermia, bladder perforation 1%, septicemia, prophylactic antibiotics required, DIC rare, anesthetic. 1. Any contraindications to neuraxial anesthesia. 2. If regional used, block to at least T10. Turp syndrome, hypertension, bradycardia, and mental status changes make up classic presentation triad. Caused by absorption of hypotonic, non-electrolyte containing solution through open prostatic sinuses, or slower absorption via retroperitoneal and perivesical spaces. Symptoms are due to IV volume expansion, electrolyte osmolar disturbance and solute toxicity, O hypervolemia, HTN, bradycardia, CHF, MI, shock, O hypoosmolality, pulmonary and cerebral edema. Note that hyposmolality may be much more significant than low NaO hyponatremia. CNS changes, dysrhythmias, O hemolysis can lead to hyperkalemia and ARF, O toxicity of infused solutes, see below. An average of 20 cc min is absorbed during procedure, but absorption rates can reach 200 ml min. Onset of Turp syndrome can be within 15 minutes of irrigation, or delayed up to 24 hours. Systemic effects of irrigating solutions. Most are acidic and metabolic acidosis is therefore a potential side effect. Electrolyte solutions disperse the electric current, and are therefore not used. Sorbitol converts to fructose and leads to hyperglycemia. Glycine is an inhibitory neurotransmitter similar to GABA and can affect the retina to cause transient blindness. It also potentiates NMDA, which can lead to CNS excitability and seizures. Note Mg2+ may be a suitable treatment for this, given its NMDA antagonism. Glycine is broken down to ammonia, which in excess can also contribute to encephalopathy. This may be treated with IV argentine, which hastens conversion to urea. Distilled water is mostly of historical significance, but causes red cell lysis and profound hyponatremia when infused. Note that water may still be used for cystoscopy, which does not result in as much systemic absorption. Mannitol dextrose dextrin blood loss. Irrigation makes assessment of blood loss difficult, and the hemodynamic response to hemorrhagic hypovolemia may be absent because of the offsetting irrigant absorption. Coagulopathy, thromboplastin released from prostatic cancer cells or TPA from normal prostate tissue can contribute to a consumptive DIC process. There can also be a component of dilutional coagulopathy secondary to blood loss and irrigant absorption. Hypothermia. Irrigation can contribute to hypothermia, particularly if not warmed. Hypothermia may contribute to CNS symptoms as well as coagulopathy. Beware the patient having continuous irrigation post-op. Their temperature must be monitored. Bacteremia occurs commonly after Turp secondary to absorption of prostatic microbes during resection. Commonly gram-negatives. Sepsis may contribute to hypotension or acute delirium. Bladder perforation, causing nausea, vomiting, restlessness, and shoulder tip pain. Note some symptoms may be confused with other diagnoses above. Intraoperative evaluation and management, history, headache, NV, agitation are early signs, visual changes, decreased LOC, SOB. Physical, hypertension, bradycardia and mental status change make up classic presentation. Pulmonary edema, elevated JVP, hypotension may occur later, from shock or hypovolemia from fluid shifts. Cardiac dysrhythmias, see table below. Pupillary reflex can differentiate visual changes from cerebral edema or glycine. Pupillary reflex intact and cerebral edema sluggish or absent with glycine. Lab, hyponatremia serum sodium ECG changes CNS changes 120 possible QRS widening restlessness confusion 115 QRS widening ST elevation NNV decreased LOC 110 VTVF seizures coma, hyperkalemia from hemolysis, HGB hemolysis, ABG. Metabolic acidosis plus hypoxemia with pulmonary edema, CRRF may occur with hemolysis, coags, serum osmolality and ammonium prevention, limit operating time to 60 minutes, the shorter, the better. Limit intravesicular pressure O limit solution bag height to 30-40 cm above prostate O surgeon must allow frequent drainage of solution from bladder, avoid use of very hypoosmolar solution, i.e., water. Spinal allows for awake CNS monitoring and decreased risk of DVT, no mortality benefit shown. Management of suspected Turp syndrome, inform the surgeon and suggest stopping the procedure as soon as possible. Reduce pressure of irrigating fluids, supportive care of oxygenation and circulation, be mindful of increased ICP if you must take control of the airway, call for help and place additional invasive monitors as needed. Labs for lights, BUN, creatinine, osmolality, CBC and ABG, 12-lead ECG changes of hyponatremia, if signs of circulatory overload, restrict fluids and consider for Lasix. If mild symptoms, Na plus, 120 or normal osmolality, then slowly restore Na balance with either normal saline or fluid restriction as appropriate to volume status, if osmolality is near normal. No intervention to correct sodium is recommended for asymptomatic patients, even in the face of reduced serum sodium concentration. Symptomatic, life-threatening hyponatremia can be treated with hypertonic saline. Before reflexively treating Turp syndrome with hypertonic saline, hypervolemia with near-normal osmolality must be excluded. Black small square. Start at a rate of 50-100 cc black small square. Diurese with furosemide, black small square. Do not exceed correction of 1.5 mec LH as this can lead to central pontine myelinolysis. Black small square. Stop 3% saline once symptoms subside, or serum Na reaches 120 if intubated. Treat remaining hyponatremia with diuresis and NS administration. Diuretics may hasten onset of hyponatremia, unless accompanied by an ACL infusion. Loop diuretics inhibit Cl uptake, resulting in urinary sodium loss, promoting salt wasting. Seizures can be treated with benzos. Consider phenytoin load for longer-term control 10-20 mg/kg slow IV. Transfer to ICU for ongoing care. OQ1H blood work, Na, K, osmolality, O frequent CNS assessment. PAR problems. Post-op delirium must consider drugs, glucose, sepsis, hypothermia, seizures, or Turp syndrome, low osmolality and Na+. Increased ICP, increased glycine ammonia, hypotension. Differential should include myocardial ischemia from volume overload, hypovolemia from third spacing or hemorrhagic loss. Decreased afterload from bacterial endotoxin load. Respiratory distress should consider laryngeal edema from fluid shifts, CHF from volume overload plus myocardial dysfunction, aspiration if decreased LOC. Note that prostatic stenting and laser resection may be considered as alternative treatments.